everyone. Good evening. So, I welcome you all to this FB Live by Apollo CBCC Cancer Care Amdavad. I hope all of you are safe and sound. So, today our topic of discussion is role of radiation in prostate cancer. And for that, we have a renowned doctor with us, Dr. Vivek Bansal from Apollo CBCC Cancer Care Ahmedabad. Dr. Vivek Bansal is a senior consultant radiation oncology at Apollo CBCC Cancer Care Ahmedabad, a center that provides 24 by 7 cancer care to patients around the world. Dr. Bansal has multiple years of experience in the field of radiation oncology. His areas of expertise are adaptive radiotherapy, SRS, SBRT procedures for different sites, IMRT, IGRT, and Repidoc treatment, MRI, and PET-CT based plannings and treatments. He has multiple publications in international journals and is also a tutor for the National Board of Trainees in Radiation Oncology. So I take a privilege to welcome Dr. Vivek Bansal. Hi, Doctor. We are glad to have you.
Pleasure here.
Yeah. So, Doctor, any welcoming remarks for our viewers?
No, I will be very happy to answer the questions because there are a lot of myths basically around the radiation. So both any questions asked are most welcome, and I hope this clears a lot of doubts in the people's viewers' mind, and I'll be able to do the justice to this topic.
Sure, Doctor. Yeah. So, Doctor, we'll start with our questions. So, my first question is what is radiotherapy, its types, and can it be curative in cancer treatment?
So, for any oncological management, radiation is probably an integral part of its management, which probably more than two-thirds of cancer treatment.
Mhm.
So, first thing is that it is essential. It is basically the myths around the radiotherapy about patient would feel burnt out, patient would have some heat. All those things I would like to clear. These things are not there, but it has to be proper effective management. So basically, radiation is a focused high energy X-rays, basically being delivered to the target only, and we try to save the surrounding normal structures as much as possible. So radiation gives the direct and indirect damage to the cancer cells, and that is how it works. In terms of types of radiation, we have generally curative or we have palliative, and either of the two can be by when it comes to the types, we can have external beam radiation, which is where the patient is at a distance from the source. We have brachytherapy, where the sources are near to the tumor or inside the tumor. So these are two different types, and we have other types of treatment by external therapy called as proton therapy, which is a new gadget. So different types, though it is an external type only, but there are different types of radiation which can be used for at any point of time depending on the stage, the type, and the site of disease. So that is so it is. But curative means when we are talking of curative, it can be standalone. So, for example, vocal cord cancer, laryngeal cancer, you don't require anything else other than the radiation for curing it. Or it can be used along with chemotherapy or surgery, either of the combinations before or after, to see that the patient is cured. And this generally is used for whenever you have little advanced stage, more than stage 2, then you try to combine it with other treatment to make it curative. So radiation is a very important modality in the cancer management.
Okay. So, Doctor, as our topic is role of radiation in prostate cancer, so now let us know what is prostate cancer, its symptoms, and staging.
So prostate is a ball-shaped organ which is placed below the bladder and behind the base of penis. The symptoms, whenever it gets enlarged because of the cancer, which is basically abnormal growth of the cells in the glandular part of the prostate, it tries to give the symptoms according to that. So basically the basic symptom for prostate cancer is difficulty in passing the urine. It can be burning in the urine, it can be high frequency of urination, more so in the night, or it could be that difficult to start the urination or control the urination while the urine is being passed. Besides that, you can have blood in the urine. So these are the symptoms which can be happening because of proximity to the bladder, whereas proximity to the base of penis, it can have problems related to ejaculation, painful ejaculation, or later part, one could land up because it is very close to neurovascular bundle. It can also give to erectile dysfunctions. So these are all very troubling symptoms for the patient, and this generally happens beyond 50 years. Not that it cannot happen earlier than 50, but this is a disease which generally happens in males, aged males, 50 plus. More so, we see around 60 plus in our country. When
Okay.
it comes to these are the symptoms. When it comes to staging, I think to make it very simple, I'll try to make it as we generally do for it is either low risk, intermediate risk, or high risk. And how do we try assess the risk? We assess the risk based on the staging, for which we will be requiring different type of imaging to decide what is the size and extensions of the disease. Is it localized or it is gone beyond the prostate? So that is the first part. So whether it is involving the nodes and everything. So that is one important thing which is used for staging. Besides that, we also use what we call as uh, the biopsy scoring. There is scoring system. When you do, we have to confirm. Nobody can say this is cancer until as you remove a tissue from the prostate and the pathologist tells you this is cancer, and he or she gives the scoring. That scoring is up to 6, 7, and beyond 7. So 6 is generally coming in the low grade, 7
Mhm.
in the intermediate, and 8 to 10 is generally the high grade. So that's how we decide. And the third important test is there is a blood test called as PSA, prostatic specific antigen test. So values of that up to 10 generally we say it is low grade, low risk, 10 to 20 intermediate, and more than 20 it is high risk. So there are different criteria to assess this patient is low risk, intermediate risk, or high risk. So this is how we do the staging for the patients.
Okay. So, doctor, my next question is what is the role of radiotherapy in prostate cancer?
So based on the stage, but first thing I will say whether it is local or advanced, radiation non-metastatic, that means which has not spread to anywhere else like bones or liver. In prostate cancer, generally role of radiation is curative. It can be standalone or it needs to be combined with some hormonal treatments or maybe with chemotherapy also. So, radiotherapy, when it comes to early prostate cancer, the choice could be either surgery or radiation. But beyond second stage, we generally say radiation is the main answer for all these things, where surgery should not be done or and it cannot be done until unless you come out with the incomplete excision of the disease where patients would again require radiation thereafter. So when it comes to curative, uh, we have 6 to 7, 8 weeks of radiation
Mhm.
vis-a-vis palliative setting where disease is gone beyond, then we have one day or 1 week of radiation. So this is a various combinations, but if the question is curative, yes, we are trying to cure this disease by radiation with or without other some treatments along with that. So radiation is mostly used for curative purposes. Though the lifespan for early prostate cancer could be different, whereas for late prostate advanced cancers, we do have some very good results also. But yes, if you are talking of, we'll discuss in the later part what is the lifespan expected in different types of treatment, of radiation treatment.
Mhm. So, doctor, as you told us that radiotherapy can be used in the second stage, and are there any other stages as well where radiotherapy can be used in prostate cancer, like in advanced stages?
So I said very clearly, stage 1 and 2,
Hmm.
radiation or surgery can be used.
Mm-hmm.
Whereas advanced stage, stage 3, and non-metastatic early stage 4, radiation is the treatment for it. Surgery is not possible in these patients.
Okay, okay, okay. Sure. Next, doctor, is how effective is radiotherapy for prostate cancer?
So when we are talking of now, it comes to like what are the results expected or survival expected in these patients. So depending on the grade of what I said, the low risk generally in fact this one other part of the staging is the survival you are expecting when we are talking of an early prostate cancer with radiotherapy. Generally If it is at least up to stage 2, we are talking of 20 years of survival also. So it all depends. There are other factors, lot of other factors to be considered before I say this. But yes, on an average, patients have a very good, not only the quantity of life, but also have a good quality of life when we are
Mhm.
treating these patients, as long as they are treated with the modern radiotherapy techniques in the best possible way with excellent um, strict protocol and good quality management. So when it comes to early prostate cancer, we are talking of results something like we're talking of 80 to 90% patients could have beyond 20 years. When it comes to advanced prostate cancer, where life expected is actually expected to be less, say less than 5 years,
Mhm.
where there also by treatment both symptom-free life can be there, and you can extend the life up to 5 to 10 years in these patients.
Okay. So, doctor, next question. I think we have a viewer's question. So, Mehal Patel, she's asking, she would love to know if prostate cancer be cured permanently.
So whenever we talk of cure permanently, I think there are two terminologies which has to be used: control and cure. So we
Mhm.
always say, first of all, for the first 2 to 3 years, we can expect a good control, and the patient survive beyond that, may say 5 years and beyond, 5 years or beyond. We say, okay, basically are cured. So yes, if I'm asked this question, depending on the stage and many other criteria which we choose, we would be I would be confident in saying if it is low grade early prostate cancer, I am
Mhm.
very clear and these patients, if treated properly with all modern technologies and everything, these patients can be cured. The problem in our country is that patients do not come for follow up. So that is a
Mhm.
basic thing. We do not have that this thing. But whatever literature reports, we are talking of 15, 20 years. Yes, in early prostate cancer, this can be cured.
So, I hope, Mehal, you got your answer. So, next we have is what are the chances of recurrence in cases of prostate cancer after undergoing radiotherapy?
So early prostate cancers, we are talking of when you talk of early stage prostate cancer treated with radiation, we are talking of when I said cure rate more than 90%. So the relapse rates is generally to the tune of 5% to 7%. But because why do we fail? Either the doses were not proper, or the techniques were not proper, or last but not the least, the biology of the disease was not good. So this is the various reasons why this patient could have failed. But generally, if at all treated properly with good mapping of the disease done by proper staging, all possible techniques properly used, good implementation of the plan which has been done on the nicely on the computer, and I'm going to touch on that what we call image guided radiation therapy. I think all these things, if it's done, we have a reasonably good chances of cure. In other words, the recurrence, if we are talking of early, 5 to 10%. In advance, we are talking about around 30 to 40% could fail, even after treatment.
Okay, doctor. So, doctor, since we are talking about radiotherapy, so what are the latest technologies used for radiation therapy?
So this has been a major transformation as far as the radiation is concerned. Like my experience the last 30 years, so I have seen the cobalt era, the machines which are outdated now, to
Mhm.
the present modern linear accelerators which has been used and which has been vogue. So lot of things have happened. What are the major changes? First, we used to plan on X-rays or basically no imaging at all. We just used to mark on skin and we used to treat patients. Vis-a-vis now we have excellent imaging techniques, images which we call either a CT scan, MRI, or PET scans. In prostate, we use PSMA scans for staging, which has been approved by American Cancer Association for staging purpose also. So all these are integrated to our planning system, where it makes our life easier to define the target properly, define the normal structures which are critical to be saved, and
Mhm.
and on top of that you have best softwares available, different
Mhm.
algorithms available on the software, which are able to give you the best possible planning based on what constraints you are given to the system, where you are able to get a good target dose and minimal dose to the critical structures. The critical structures in prostate is basically main important thing is rectum. Because
Mm-hmm.
if that was the criticism for radiation by the surgeons earlier, that if you
Mm-hmm.
go for treatment, you have bleeding from the rectum. So how best you can deliver a high dose to the prostate and save the rectum from the high dose area, that is something the differential which we have to achieve by these systems and modern softwares. And then on top of that, the good equipments which are there on the linear accelerators, what we call, they have imaging devices on the treatment. Was never heard of. Planning, yes, the planning system is one part, and
Mm-hmm.
to check whatever you have planned on the computer is rightly being delivered on the machine or not. You have imaging devices which verifies if there is error that corrects, and then you treat. This is called as image guided radiation therapy. So we have CT scans available on the treatment machine, which gives you three-dimensional information, and virtually it tells you that your patient is now being perfectly placed, and then you treat this thing. So gone are the days when we used to see that kind of complications 20 years before. Nowadays, hardly you see any much complication as long as you have good planning and good execution.
Yeah.
So we started from basic 2D planning. We have come to three-dimensional plannings now. We have,
Mm-hmm.
on top of that, we have got a new that was everybody has heard IMRT, intensity modulated therapy. Under image guidance, if delivered, you are going to get the best of the results. I would like to mention here, this radiation, as I said, curative generally goes for 6 to 8 weeks, but now you have different methods. Because technology improvement is there, you could complete in select patients. I repeat,
Mm-hmm.
in select patients, you could deliver this treatment anything between 1 week to 3 to 4 weeks also, without any complications and without any compromise in the local control.
Mm-hmm. Nice, nice, doctor. So, doctor, I think we are done with our set of questions. So, let's take some viewers' questions. So, here I can see Pragya Khanna. She is asking, when is radiotherapy needed after a prostate surgery?
So I'll answer in this way that if a surgeon has done a good job, has selected the right patient, for the surgery generally in the good hands because of
Mm-hmm.
new robots available for the surgery, generally you may not. But if a badly selected cases or badly mapped patient, I'm not talking of that 2 or 3% where you open what was given on the imaging and what you see after opening up, that could be two different things. But generally, if I have to answer this question, there are two things. One, if you have the margins positive,
Mm-hmm.
if you have nodal positivity on the histopathology report given by the pathologist after the surgery, or this, that is the one where you have to probably give the radiation immediate, or seminal vesicles involved upstaging of the disease, there probably you have to give radiation within 4 to 6 weeks after surgery. But there are different way. Sometimes you may have a what we call the signs of recurrence is by rising blood test marker level, that is PSA. So if
Mm-hmm.
this PSA is rising and has gone beyond 2, then probably maybe whatever time frame it goes up, 6 months, 1 year, 2 years down the line, that time you have to give the radiation to see that this patient is cured.
Okay.
Hence the importance of good staging and good mapping of the disease prior to
Mm.
surgery or prior to radiation, anything for that matter.
Okay, okay, doctor. So, next we have is Miss Shomona. She is asking, are there different types of radiation used for the treatment of prostate cancer?
Yes, there are different types. So one, as I discussed, by the
Yeah.
external beam, you have linear accelerators available. You have proton therapy available for the where the patient is at a distance, and you treat the larger volume of the disease. We
Mm-hmm.
also have in like in Europe and in USA where patients are diagnosed much earlier, maybe on the screening where the screening is mandatory for aged males. You try to detect this disease much earlier. There probably what we call as brachytherapy, where you put the needles in the prostate under the sonography guidance, and whether it is a permanent implant or temporary implant, what we call implant means the brachytherapy. These patients can be cured without any external treatment also. So this is the different ways you can be treating these patients by external or by brachytherapy.
Okay.
But you need to choose your patients very properly when it comes to brachytherapy only.
Mm-hmm. Okay. Okay, Jonathan. Next question is, what are the side effects? So, are there any side effects of radiotherapy?
So whenever we are treating the prostate, any treatment for that, whether it is surgery or radiation, they will all have a little bit of side effects. So
Mm-hmm.
burning in urination is probably the one of the commonest side effects during the course of radiation. Patient would tell you, and
Mm-hmm.
occasionally there can be you could patient's urine can be you might have to catheterize because it's stopping, and then that can be a difficult situation. Very rarely, some patients do say that we have diarrhea or nauseating sensation. Those all can be taken care by the routine medications which we are able to give. But very important, whenever we give radiation, a good preparation during the planning and during the treatment with some dietary restrictions, if it is given, generally you don't see these issues, but burning urination can be there.
Mm-hmm. Okay.
But they're
Okay.
all temporary, not permanent.
Okay. 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 Yeah. Next is Fagun Shukla. He is asking, Doctor, should I be scared if I have prostate cancer?
Not at all, Mr. Fargun. In fact, what is important is I always say to my patients, come at the right time to the doctor. Open up very clearly that whatever your symptoms and whatever investigations you have done, doctor would advise you a set of investigations. Stage it properly to decide what kind of treatment you would mandate. But important to say, if you are early, low risk disease, we may ask you just no treatment, just come for the regular follow-up. So this is one of the management, the active surveillance. If you are early prostate cancer, very early prostate cancer, and it is a low-grade disease based on the biopsy and different scoring systems which I have conveyed, not necessary you would be a candidate for any treatment. You ask, we ask for surveillance only. If you're and there's no compromise on the overall survival, you need to follow up at any point of time. We feel that the markers or anything is going haywire, then probably treatment can be given without any compromise on the control. So you should not be afraid of, rather come at the right time, have your disease mapped properly, and then
Mhm.
get treated accordingly.
So that basically concludes that right diagnosis at the right time will lead to right treatment, and that will help us to beat cancer.
What is important is that every institute, I mean, talking first important thing is these treatment should be given in an institute where they have multidisciplinary teams and cases are properly discussed in the MDT or multidisciplinary tumor boards and arrive at the best possible solution. I think this is where the way the things are changing. And if you have implemented this thing, and many minds are working together to decide what kind of be the treatment should be appropriate treatment should be given for this patient, chances of going wrong is very less. So that individual bias can be there, but if the board is deciding, then you are arriving at probably the best possible solution for the patient. So that is so important.
So next we have is Pankaj Singhal. He is asking, is the therapy very painful as other cancer treatments?
So, Mr. Pankaj, I would like to clear your doubt. This radiation treatment is painless. Now, when it comes to external treatment, brachytherapy, as we discussed for the external treatment, it could be little bit of skin changes, little bit of burning in urination, as we discussed. Besides that, I don't envisage any problem as far as external treatment is concerned. Proton therapy has more better things in terms of reducing the side effects of the treatment as compared to photons delivered by linear accelerators. But when it comes to brachytherapy, it could be a little bit painful. But these procedures are done under anesthesia, and they are, when you are giving this radiation by brachy by putting the needles inside, patient remains for 2 to 3 days if it is high doses. There you are under anesthesia for that 2 or 3 days. So generally the treatment is painless, but everything is manageable in next 3 or 4 days. Thereafter, the patient is discharged.
Mhm. Okay, okay, doctor. So I think, doctor, we have one more question. So Surendra Singh, he's asking, what is Gleason's score written in patho report? So I think it's a very technical question. Maybe you'll understand that.
It is the Dr. Surendra Singh Solanki.
It's Surendra Singh Baldar Singh Solanki. Yeah.
May not be said that. Anyway, the Gleason scoring is given by the pathologist based on the biopsy specimen sent by the surgeon, and there you have two types of sample. The first one, which is the more common, he gives you one particular score, and then he gives you the second commonest one. So combination of these two scoring will tell you whether the score is 6 or less.
Okay.
7, which is 6 or less, is in low grade, 7 is intermediate, and the total score cannot be more than 10. So 7 to 8 to 10 is high grade. So that is the scoring given by the pathologist, and we
Mhm.
decide based on that.
Okay, okay, doctor. So, yeah, we have one more question from the same person here. Uh, the question
Okay.
is it possible for complete cure if the cancer stage is very initial? What are the chances of re-emerge of the disease, and what are the survival chances? So basically, you have answered all of the questions, but if you could,
Very good question, but I'll again put it very simply. We are
yeah.
talking of very long survival. I like to clear this in a little more elaborately now. We are talking of extremely good survival in these patients if everything has gone well in terms of accurate staging, accurate planning, and accurate treatment for these patients. We are talking
Mhm.
of 20 years. We don't have data in India for long-term follow-up for these patients, but for whatever Western data we are getting, we are talking of very long time survival for these patients in early prostate cancer patients. Little later, little advanced, that is stage 3 or early stage 4, we are talking of survival to the tune of 60 to 70%, a little more. They have to be combined with hormonal treatments or maybe some chemotherapy along with this radiation also.
Mhm.
I would like to point here that earlier we used to write off the cases where disease was besides the prostate. If you have one or two bones involved, we completely 10 years, 15 years before, we used to write off these cases, only give palliative treatment and some hormonal treatment and all that thing. Do not go beyond that. But now, with data emerging, we call as oligometastatic, means two or three bones. I'm not talking of liver or something else. Bony involvement, two to three. Cancer, prostate, generally, if it spreads beyond local extension, generally, mostly it is bony involvement. So one or two spine or pelvic bones are generally involved. If one or two bones are involved, then the data is now emerging that besides treating the prostate, you also treat these bones, and these patients will do very well, almost like same what a curative patient would go for. But yes, we are talking these patients, we are talking of 5 to 10 years survival. In metastatic disease also, where the patient's disease gone to bones and other areas, we are talking of 5 years. These patients are not going to die in 1 year or so if properly treatment is given. If treated properly, these patients are also going to live for 5 to 10 years also. So, what is important is proper, accurate mapping, accurate staging, right kind of treatment, multidisciplinary team decisions, and then
Mhm.
implement.
Yeah, true, doctor. So, I think we have no other questions. So, doctor, anything you would like to conclude with?
I think one thing, if God asks you in the males what kind of disease in cancer, if it is to begin, then probably one thing you should choose is the prostate cancer. Here we are talking of long-term survivors. Here we
Mhm.
are talking of good treatments if get delivered, whether it is surgery or whether it is radiation, does not matter. Rightly implemented treatment, you are probably going to get excellent outcomes and excellent this thing. But both team, when I say team means that when it comes to radiation, both the treatment doctor, the physicist who are actively involved in planning, my technical team who does a lot of imaging during the treatment, as I said. So if
Mhm.
you have right team, you have right technology with you,
Mhm.
you should not be afraid of that my cancer would not be cured. I would say that good team, and that for same thing for surgeons. If you have
Mhm.
robot, but if you don't have a good team of surgeons, you are going to fail. So if
Yeah.
good surgeon, good robo, you can do wonders. And same thing with radiation also. If you are rightly getting the right kind of treatment, properly discuss with your physician what should you expect out of the treatment. During the
Mhm.
course of the treatment, review weekly once to check or changing the treatment, everything. You should be talking to your doctor nicely. Implement whatever doctor has said, because it's not only the treatment doctor's responsibility, it is the equal responsibility of the patient to follow the instructions. As I said, dietary regimen, there are a lot of things we say doctor patients not to eat properly. If they follow you properly in all these things, you are not going to land up in complications. So all those things has to be taken into account to see the successful outcomes, and that is where you will be succeeding.
Yeah.
Technology alone cannot help in that thing.
Hmm. True, doctor.
I,
True. Yeah. So, doctor, a lot of people are thanking, and I would also like to thank you for delivering such interesting and insightful session. Thank you so much for that.
thank
Yeah.
you very much.
Thank
Thank
you
you very
so
much.
much, viewers, for joining us. If you ever need a cancer consultation or treatment or anything else related to cancer, you can definitely visit Dr. Vivek Bansal at Apollo CBCC Cancer Care, Ahmedabad. Thank you so much. Thank you so much, doctor.
Nice meeting you, talking to you.
Yeah. Thank you
Okay.
so much. Yeah.
Thank you.